Hey everybody, let's talk about ACL reconstruction. I would say of everything that we talk about in this postoperative class, we have the most research regarding ACL reconstruction. There's a lot of stuff out there. We're going to try to condense it down, and I'm going to try very hard to make this as relevant as possible for the patients that you guys are going to see. We are definitely doing this as a two-part series here of presentations. This first one, we're going to go through the surgery, and then the second part is going to be focused on rehab, especially return to sport, which is a big thing we need to consider. So today we're focused on looking at anatomy, reminding ourselves of where the ACL is, reminding ourselves of all those ligaments around the knee. So let's start with that. So here's just a nice picture of the knee, and we're looking at the non-contractile tissues. And so you can see a picture right in the middle there is the ACL. The ACL is going to come from the anterior and middle portion of the tibia and then go to the back portion of the femur. You also have the PCL right behind it that's along the posterior aspect of the tibia and the femur. And then you can also see the meniscus, which we've already talked about there, lateral meniscus and the medial meniscus. You can also see the LCL, the lateral collateral ligament, on the left, and the MCL, the medial collateral ligament, on the right. So let's look a little bit more. This is on the inside and the outside of the knee, so we can look a little bit more here. And this is where we're kind of seeing the soft tissue, so the contractile tissue, as well as in this case the medial aspect of the knee, where you can see pictures of the MCL, and then you can imagine the LCL on the lateral aspect of the knee. So when we talk about the ACL, again, we know that the ACL comes from the anterior portion of the tibia, but there's also what we call the PL portion. So the anterior is from the anterior medial aspect, so it kind of attaches a little bit to the medial meniscus. And then we also have this posterior lateral portion that's, again, coming from sort of the middle of the tibia. You can see that here. It says on the right, you'll see the PL, sort of the pink-colored ACL portion. And so that one comes a little bit more to the lateral aspect of the femur from the middle of the tibia. So there are two sort of different portions that separate out a little bit. It's important to remember that this anterior medial portion attaches to the medial meniscus because we oftentimes end up with injuries to what we call the terrible triad, which is that sort of anterior medial portion pulls on the medial meniscus and maybe even the medial collateral ligament, and we end up with tears of both the ACL, the MCL, and that medial meniscus. So you can see how, just looking at the anatomy here, how that can definitely happen because they are very close to and they do attach to each other. So our stability of the knee, our sort of passive stability, so non-contractile tissue would include the ACL and PCL, as well as that MCL and LCL, and then the posterior lateral corner, which is basically just connective tissue. That basically is mostly a lot of kind of what comes off of the IT band. We also have active stability, which is by the quads and hamstrings, the popliteus muscle in the posterior part of the knee, and then the hip abductors and adductors. So what does the ACL do? ACL, I think most of us know it resists the idea of anterior tibial translation. So it stops that ability of the tibia to move too far anteriorly when we plant the foot. It also helps to resist flexion and extension, and then frontal and axial motions, meaning rotational motion. So again, when I plant the foot, it helps to stop my femur from twisting too much on my tibia. This is another picture that kind of shows you that anterior medial portion and how it attaches, as well as the posterior lateral portion, and how they are kind of separate bits of ligament, and they kind of run in a little bit different directions. So thinking a little bit about the MCL and the LCL, MCL is relatively common for an injury. 7.9% of all athletic injuries are going to be MCL. And oftentimes, as I said earlier, it can occur with injuries to the ACL and the meniscus. These usually occur when there's some sort of external force on the knee that causes the knee to go into valgus. And so that valgus position will cause tears to the MCL, as well as possibly the ACL and the meniscus if it's bad enough. The LCL actually has injuries from a varus force, and it's a lot less common to actually injure the LCL as well as the lateral meniscus. We talked a little bit about the lateral meniscus when we talked about meniscectomies, and just the fact that it's much thicker, it's much more stable. We don't tend to have injuries to the LCL very often or the lateral meniscus. ACL injuries by themselves can happen with contact or non-contact injuries. So non-contact injuries would be some sort of just deceleration where you have the quad contracting too much and the hamstring isn't contracting enough, so it ends up pulling things forward. And that happens about 70% of the time. So it's less likely that we get hit by somebody and more likely that we just have this muscle imbalance. It also can just be increased load on the ACL with too much valgus. So it's either quad that contracts too much or a valgus force. Contact injuries are about 30% of the time, and this tends to be what we see on sports videos, in basketball games and football games, and it's where you have a sudden deceleration and a twisting motion, and then somebody's hitting us. So oftentimes we're getting this combination of stopping too fast and doing rotation and possibly hyperextending the knee. This can be with somebody hitting us or just on our own, and we're more likely to get that ACL tear. So we're looking for a story like that from our patients if we're not sure whether or not they have a tear. The highest incidence of ACL injuries happen in professional athletes, as we said earlier, as well as in the military. And then it happens in amateur athletes as well. So we're much more likely, I think, in our settings to see the amateur athletes, the younger athletes. Adolescent females are much more likely to have this injury, and they think that's partially because of different hormones, and as we develop, hips become wider than knees, and so we end up with more valgus of the knees in standing, and then we therefore can have more valgus stress with knees during activities. So you're going to see ACL tears in adolescents, a lot more common in females and less common in males. Diagnosis, they should be able to report a trauma. And I say this about all ligament injuries. Ligament injuries, it's very, very, very rare that we get a ligament that has gotten torn over time somehow. You really should be hearing some sort of story about some sort of trauma. And usually that trauma will include deceleration, cutting, valgus, just the things we just talked about. Most of the time they will tell you they hear a pop, and they'll feel that pop during the time of the trauma. And then remember that the hemiarthrosis, or basically edema, redness, all those things, are usually not occurring right away. It usually will take a couple of hours, but usually within 0 to 12 hours following the injury, they're going to develop swelling, redness, things like that. But if you're testing the ligaments immediately following an injury, you're less likely to be able to get a very good test. And we'll talk about the tests here in just a second, but recognize that immediately following these types of injuries, there's a lot of muscle guarding, and we're not seeing the swelling yet, and so it's a lot more difficult to use the tests that we can do to make a good diagnosis. So again, diagnosis is going to be knee effusion, knee swelling. It's not usually showing up right away. It's very rare that it shows up right away. But as time goes on, they will tell you, yes, I had some swelling the next day. I also felt like my knee was unstable. And the test that we use the most, that has the best research behind it, is what's called the Lachman test. And again, if we have a lab, we'll definitely review Lachman's testing. It has the best research for sensitivity and specificity. And so when we perform that test, we're expecting that the difference in instability is several centimeters more, usually 1 to 2 centimeters more movement than on the uninvolved side. And there's different research to say different amounts of increased translation, but just recognize that the translation is increased with a Lockman or an anterior drawer test compared to the uninvolved side. And then obviously MRI. MRI is what's going to provide that definitive diagnosis of an ACL tear. So here's pictures of an MRI. You'll notice on the left here that that is a full ACL as opposed to the one on the right where there's an obvious tear. And most of the time it is pretty obvious in an MRI. So there are lots of special tests for ACL. Knee palpation, again, you're looking for swelling, irritability. You can do varus and valgus stress tests for MCL and LCL. Posterior drawer is going to be used for PCL or posterior sag sign for the PCL. And then Lockman, anterior drawer, and pivot shift tests are used for ACL, with Lockman having the best research. So we graded, if you remember, in the last presentation on ankle ligament reconstruction. We used the same grading system. So this is the grading system we use for ligaments in general. So a grade 1 is a mild sprain, no disruption of the ligament, whereas a grade 2 is more moderate, where there's partial tearing of the ligament, and grade 3 is a complete disruption of the ligament. We do have guidelines, and these guidelines are excellent, you guys. As I said, there's so much research that, of course, we're going to have some guidelines. The revision of the knee stability ligament sprain guideline was done in 2017. This revision really focuses on ACL and rehab following ACL reconstruction. So that is the focus. And you'll see here, I just want to go over the recommendations, and then we're going to go into a lot more detail with these things. What I think you want to look at here is more of the interventions. So when they talk about recommending special tests and diagnosis and stuff, again, the Lockman's is the primary test. And so for treatment, what you will see is that there is not great research related to using something like a continuous passive motion machine or CPM machine. They say it might help to decrease pain, but that's about it. So it doesn't really help with changing mobility a whole lot. There's also research, again, level C, not great, but there is research to talk about early weight bearing, and that within 1 week after surgery, you can start weight bearing with these people. It doesn't hurt anything to start weight bearing within the week. For knee bracing, you'll see that you can consider using a functional knee brace. That's a level C. But in terms of, you'll see that there's a level D that says that there's basically some research that says you should use it and some research that says that you shouldn't after surgery. So this is ACL deficiency. So we're going to talk about those people who are copers, who don't end up getting ACL replacement. And those, again, that's a level C research that says that those people can be using braces. But after surgery, there's not good research to say that they should be using braces for ACL. For PCL, MCL, and posterior lateral corner injuries, that they say, again, this is level F, so this is not good research, but the level F research says that you can be using bracing. So again, the only time that there's any somewhat okay research regarding bracing, it's for your patients after ACL injury, but not surgery, to allow for more stability. There is, however, level B research to talk about immediate mobilization following surgery. So that's pretty good research to say that within 1 week, we should be mobilizing, meaning moving the knee. We should be moving the knee. So we need to increase range of motion, decrease pain, decrease swelling, all of those things, especially focusing on extension, which we'll talk about in more detail later. Level B research to talk about using cold following ACL reconstruction. So that is something you should consider. For interventions, doing supervised rehabilitation, so actually coming to therapy, as well as doing a home exercise program, has level B recommendations. And then we have some level A recommendations for specific types of exercise. So therapeutic exercises has level A recommendations. Eccentric exercises implemented at 4 to 6 weeks, and that would be done 2 to 3 times per week for 6 to 10 months. Okay, so there's great research to show that this type of exercise started at 4 to 6 weeks and performed 2 to 3 times per week is what's going to be helpful, as well as neuromuscular re-education and neuromuscular electric stimulation. So we love to talk about, I've talked about NMES with you guys before. Neuromuscular electric stimulation, we've talked about it with total knee replacement. It also can be very, very helpful with these patients. And they should be using it on their quad, specifically the quadricep muscle, for 6 to 8 weeks to help make sure that that quadricep muscle is contracting well. Also, neuromuscular re-education should be used for helping to, again, control the knee. So doing this in conjunction with the strengthening the eccentric exercises. So we do have these patients that are non-operative, and some doctors say, you know what, that's a grade 2 tear maybe. We don't think that this is that bad, so instead we're gonna say no surgery, and we call these people copers. And these copers tend to do usually actually pretty well. If you're seeing these patients who are not having surgery, which I have really not seen a lot in China, there aren't a lot of these people. Most of the time the doctor will do surgery. But in the US, they're starting to do it a little bit less. And so if you're seeing those people, you really want to make sure they have full range of motion, especially extension. Extension. You want to make sure that their quadricep and hamstring ratio are equal. So remember, these things can happen if the quadricep becomes too powerful. But after the injury, oftentimes their quadricep becomes very weak. So you need to make sure that before they discharge, their hamstring and their quad are working equally together during functional movements. You also need to make sure the hip is strong and that they're doing that proprioceptive training, so neuromuscular re-education training. We talked a little bit about this with just that ligament introductory presentation, and I talked about it with the ankle stuff. Remember that with these tears, especially if they're a mid-substance tear, we're not sure if their mechanoreceptors come back very well. So we think the ligament heals, but we're not sure about the nerve substance within the ligament. And so we really want to make sure that we're doing a lot of proprioceptive training to make sure that any mechanoreceptors and any other proprioceptive nerve endings that can be working in the knee are working very well. So there's a couple of these Delaware Oslo cohort study research articles out there from the last couple of years, and they talk about how you can compare the non-surgical versus surgical treatment for ACL. And so you'll see this one was done in Norway. Actually, they've all been done in Norway for the most part, although this one was done in Delaware. So we have research in both Delaware and Norway. And what they've basically did is they put together about 300 patients initially, and about more than half actually had ACL reconstruction. And then 118 actually did not have ACL reconstruction, and they followed up with them for 2 years. And they found that a lot of their outcomes were very, very similar to those that did have ACL reconstruction. So again, you might start seeing a little bit more of your copers out there, your patients who you just have to strengthen and work around it just like you would with any ligament. So think of your ankle sprain like we talked about with our ankle ligament reconstruction. It's very similar. You're just working the muscles or the contractile tissue around those ligaments to make sure that it's helping to stabilize if they don't have a complete ligament. So let's spend a little bit of time talking about surgery. I'm going to show you the videos first, and then we'll talk a little bit more. When we talked about ligaments, again, in that introductory presentation, I introduced this idea of allograft versus autograft versus a synthetic ligament. And what I'm going to show you are two videos today that are two different allografts. Two different autografts. Autografts being from your own body. So the first one is going to show you how they replace the ACL with a patellar tendon. And the second one, which honestly sounds almost exactly the same up until that part, they're replacing the ACL with a hamstring tendon, usually the semitendinosus tendon. So it's going to sound very similar. We are going to watch both of them though, because I think it's good to see this surgery technique twice. So we'll do that first, and then we'll talk about them in a little bit more detail.
The anterior cruciate ligament, ACL, is one of 4 ligaments that are crucial to the stability of your knee. It is a strong fibrous tissue that connects the femur to the tibia. A partial or complete tear of your ACL will cause your knee to become less stable and feel as though your knee is about to give out. There are a number of different graft options to replace your torn ACL. Your surgeon will select the option that is best for you. Small incisions are made around the joint. The scope and surgical instruments will go into these incisions. The scope is inserted into the knee. Saline solution flows through a tube, cannula, and into the knee to expand the joint and to improve visualization. The image is sent to a video monitor where the surgeon can see inside the joint. A surgical instrument is inserted into the joint and the torn ACL is removed. The central portion of the patellar tendon is removed using a scalpel and motorized tool. The ends of the tendon are attached to plugs of bone from your patella and tibia. These plugs of bone will help anchor what will become your new ACL. A guide wire is inserted through the tibia and femur to help accurately drill tunnels. A surgical drill is inserted over the guide wire, and a new tunnel in the femur and tibia is created for the new ACL graft. The end of the graft is tied to a loop on the guide wire, and the graft is pulled into place. Screws are used to secure the plugs of bone into the tunnels. Over time, the plugs of bone will incorporate into the surrounding bone. With the new ACL in position and secured, the surgical instruments are removed and the procedure is completed. The anterior cruciate ligament, ACL, is one of 4 ligaments that are crucial to the stability of your knee. It is a strong fibrous tissue that connects the femur to the tibia. A partial or complete tear of your ACL will cause your knee to become less stable and feel as though your knee is about to give out. There are a number of different graft options to replace your torn ACL. Your surgeon will select the option that is best for you. Small incisions are made around the joint. The scope and surgical instruments will go into these incisions. The scope is inserted into the knee. Saline solution flows through a tube and into the knee to expand the joint and to improve visualization. The image is sent to a video monitor where the surgeon can see inside the joint. A surgical instrument is inserted into the joint and the torn ACL is removed. A portion of the hamstring is removed using a specially designed surgical instrument. The hamstring graft will be folded over to increase strength. Both ends will be sutured to facilitate passage through the tunnels and into position. A guide wire is inserted through the tibia and femur to help accurately drill tunnels. A surgical drill is inserted over the guide wire, and a new tunnel in the femur and tibia is created for your new ACL graft. The end of the graft is tied to a loop on the guide wire, and the graft is pulled into place. There are a number of devices available to fixate the graft into place. They range from staples, post and washers, and button-like devices. Your surgeon will decide which is best for you. In this example, a cross pin is used to secure the graft. Over time, the tunnels will fill in with new bone. With the new ACL in position and secured, the surgical instruments are removed and the procedure is completed.
Okay. So that gives you an idea of what to expect from the surgery itself. Those are both autografts, meaning, as you saw, we use patellar tendon or we use hamstring tendon. This month, actually, we have brand new research that talks about the healing timeframes for one versus the other versus allograft. And we'll talk about that a little bit more in the next presentation. But what you do really want to keep in mind is there's so much research out there that ACL healing timeframes are really what we kind of use for all ligaments. So we kind of recognize that the research is done mostly on ACLs, but that these types of timeframes can be somewhat similar with any autograft that is being used with the ligament or allografts being used for a ligament. So with ACL, by the 4th week, we have that synovial membrane that begins to envelop the graft. So it's not until 4 weeks that we start to get synovial fluid around the graft. Before that, this is just a hamstring tendon that's standing in for an ACL, okay? That synovial membrane is completely enveloped the graft by 6 weeks. So at that point, we have synovial fluid getting to that graft. And by 8 to 10 weeks, you'll start to notice blood flow. You'll start to see evidence of blood vessels. However, it's not until about 20 weeks that the graft has full blood flow. Okay, so 20 weeks, you guys, this is 5 months. Please keep that in mind. You don't have full blood flow to an ACL until 5 months later. So for these patients that you're trying to get back to return to sport too early, you have to recognize that they do not technically have ACL blood flow until 5 months. It's really important that you understand that, because I'm seeing that, there's these hotshot physical therapists in China who are saying, okay, let's start having them run at 3 months. And it's like, you can't do that. You can't put unnecessary strain on the ligament. The ligament needs time to heal. So unfortunately, by putting too much strain before this 5 month time frame on these ligaments, you end up having re-tears and other injuries. Also keep in mind that it's not until about 18 months that we actually see that the synovial membrane is completely intact and that the tissue itself looks like native ACL. Okay, so it looks more like what we would see in a normal ACL. 18 months, guys. Again, a year and a half, okay? So it's not worth it to try to push these people too hard, even if they're feeling great, because we don't want to end up with revisions, and it happens, unfortunately, a lot with ACLs. Okay, so you have to memorize this time frame, okay? And I always tell it to my patients at the beginning. This idea that starting at 10 weeks, we start to get blood flow. So between 10 weeks and 20 weeks is a really important time frame to be very careful with the knee, because that's the time frame that people tend to think that they're doing great, but remember that ACL is not their ACL. So 10 weeks to 20 weeks, guys, keep that time frame in mind. Make sure your patients know you still have to be careful during that time frame. Allografts are a little bit slower. Allograft is where they're harvesting the tissue from a cadaver. It's very rare to see this in China. Usually when we do see it, it's for somebody where they have to have a revision and they don't have good tissue from their hamstring or their patellar tendon. And so they're using an allograft. But I know in China it's kind of not culturally okay or acceptable to use something from a dead body. And so it's a lot less likely that we're going to see that here. But they do take longer to actually become part of our own body. So that 10 to 20 weeks thing that we just talked about with an autograft, we're thinking you're adding on about 4 or 5 weeks to that. They also tend to not be as strong as if we can use an autograft. So autograft is the better way to go. But what we're seeing here what I'm seeing a lot in China is synthetic grafting. And so this is a very, very new procedure to use some sort of synthetic ACL, so something that's not part of them. Usually what they do is they make, we talked about this a little bit with that introductory ligament presentation, they make sort of a scaffold that then they allow the tissue to sort of develop around the scaffolding or synthetic tissue. we're going to say that they probably heal faster than the allograft for sure, and maybe faster than an autograft, but we don't know because we just don't have the research yet. So I tell people to follow the same time frame that we talked about with the autograft for a synthetic graft. So again, that idea of you can't get synovial fluid and blood flow in there until 10 to 20 weeks. So it's not possible for our body to go faster than that. So I would say continue to follow that time frame even if you're recognizing it's a synthetic ACL until we have more research to tell us differently. So precautions, things to think about, is we're basically going to, if they are not having surgery right away, we're going to have them, usually weight bearing is tolerated with crutches. Healing timeframes, I kind of already just talked about this. I've talked about it several times. So just remember that you do have sort of the inflammation phase, just like you would with any type of tissue injury, and then the proliferation phase, and then the remodeling phase. So that's what we follow with every type of tissue, and we're following that with this as well. Before surgery, it's really, really helpful to get the patient to tolerate full knee extension. They also should have full knee flexion, but as I've said before, knee extension is one of those things that is going to be one of your primary goals during the first phase of post-operative rehab. And so if you can get that good knee extension and quad contraction before surgery, it's going to be an easier process for you after surgery. Again, good quadricep strength. And then full knee flexion, also helpful, but it's not as big of a deal because most of the time you can get flexion. It's just a little bit slower, but you can get functional flexion relatively quickly. The last thing I want to review today are the knee soreness rules. If you remember, we talked about these with Module 1, and it's just something to kind of keep in mind as we talk about rehab. This idea, I think, can go really with any type of patient who has pain. You really can kind of follow the same idea. And the idea here is that if the patient's reporting soreness, and oftentimes they can pretty well differentiate between soreness and pain, but you don't want knee soreness. Muscle soreness is obviously different, but if they're reporting knee soreness during warm-up that continues throughout your exercise program with them, then you want them to actually stop the exercise program, take 2 days off, and then when they come back, drop down 1 step so that you're decreasing that soreness. If they're reporting knee-specific soreness during warm-up, but it goes away as they start exercising, then you basically are staying at the same level of exercise that you are doing at that time. If they have soreness during warm-up, but it goes away and then redevelops as they continue doing their exercise, this looks just like the first one. You're taking 2 days off. When they come back 2 days later, they're going to drop down 1 step. If they have soreness the day after lifting, again, this is not muscle soreness. This is joint soreness. This is deep soreness in the knee. You're going to take 1 day off, and you're not going to advance the program. You're just going to take a day off, and the next time they come back, you're going to stay at the same level. If they have no soreness, so they say, yep, I feel great, then you're going to advance 1 step per week, okay? So you're going to kind of increase level of intensity, increase weight with strengthening, all of those things every week. So this is just a nice rule of thumb, I think, to think about with any of your patients. Again, could be somebody who had a rotator cuff repair. It could be somebody who had a knee replacement. All of those things are appropriate to think of these rules. So we're going to stop here. We're going to come back and talk about rehab and return to sport in the second half.